Thank you, Chairperson, for the nice words. Thank you, audience, for being here for this session. And I will assure you, you will not be disappointed. Thanks to organizer, especially Dr. Banshi, Dr. Manoj Chawla, Dr. Amit, for inviting me to this August gathering of diabetologists. Topic for today is insulin initiation in type 2 diabetes. Why, when, and how. This is what we see day in and day out. And this is the reality that HbA1c control in Indian diabetic patients is suboptimal. How many of you feel similar things? Raise your hand. There is nobody in the hall who says that, yes, we are on target. And these are the various observational studies which say that HbA1c is something which is not under control. It ranges from 8.5 to 9.3. Look at the A1C. Similar is for fasting and TTG. So, what is the effect? This glycemic legacy leads to various complications. 30 to 50% of our patients in day-to-day practice have suboptimal control before treatment is escalated. Whatever may be the reason, it may be patient factor or physician factor. इंसुलिन से सबको डर है, डॉक्टर हो चाहे मरीज हो, especially in India. Prolonged periods of uncontrolled hyperglycemia increases the risk of diabetes associated various complications. This is a fact that good glycemic control is very important. It leads to even reduced life expectancy. Why insulin? Ticking clock hypothesis. समय बीतता जा रहा है, हम लोगों को कुछ करना है. Risks are there of delaying insulin. Microvascular complications start at the onset of hyperglycemia, maybe even before that. Now we have evidence for that. And definitely macrovascular complications, the cardiorenal complication, the atherosclerosis starts very early in our life and patient's life. Why insulin? Treatment of type 2 diabetes and beta cell function. In type 2 diabetes, there is progressive deterioration of beta cell function. This is how it may go in majority of our patients. We need to start with lifestyle. In lifestyle, I am a strong proposer that lifestyle itself is sufficient in majority of pre-diabetics and some of the diabetics also. If treatment is needed, you can start with oral agents. And now we have various oral agents, or short-term insulin to begin with is needed in type 2 diabetes patients. If insulin is required after that, it can be basal insulin or basal insulin plus GLP-1 RA, long-acting one, may be started at the and added to what oral hypoglycemic agents we are giving, or it can be basal class or basal bolus therapy. Everybody knows about it, but we often don't practice. There are many benefits of timely initiation of insulin. Gone is the era when we used to say that early insulinization is effective. Now is curable for type 2 diabetes. Now we know that timely initiation is important. It reduces glucotoxicity, lipotoxicity. Beta cell exhaustion is taken care of this insulin starting. Amyloid deposition, which is very common in type 2 diabetics as they age and oxidative stress goes down. Other benefits of insulin, it has got anti-inflammatory action, cardioprotective, neuroprotective. Any emergency, it should be used. Vasodilator and anti-thrombotic action is there with insulin. Platelet inhibition, antioxidant, anti-apoptotic. Probably none of the drugs used today has so many actions beyond glycemic control. Why insulin? It should be started at the diagnosis with a symptomatic patient who presents with hyperglycemia, maybe fasting of more than 250. Here I have underlined symptomatic patient. The hyperglycemia symptoms should be there. The weight loss, polyuria, polydipsia, polyphagy is very, very important. PPG, which is more than 300, or A1C of more than 9. And any diabetic patients with septic infection, systemic infection, sepsis, myocardial infarction, unstable engine. And nowadays we see number of cases being first time diagnosed with diabetes in CCU admitted because of unstable angina or AMI. Ketoacidosis, hyperesmolar non-ketotic coma. Anybody who is pregnant, maybe at the time of diagnosis. Dr. Latika gave very good deliberation about pregnancy and insulin use, perioperative care, especially in nil organ. Minor operation में जरूरत नहीं पड़ती, IOL कराना है तो जरूरत नहीं पड़ती. But a patient who needs to be nil oral, chronic kidney disease patients should be on insulin. Short-term use of insulin, maybe similar indications are there. After OAD failed to achieve, majority of us see day in and day out initiation of insulin because of various factors, maybe patient related or doctor related. Despite receiving optimal dose of 2 to 3 anti-diabetic drugs, fasting more than 150, postprandial or random blood sugar of more than 200, and A1C of more than equal. Remember, we must start insulin even in asymptomatic type 2 diabetes. How to start? What is the choice of insulin to begin with? Factors which affect our choice of insulin. Maybe history of, this is age and duration of diabetes, diet pattern, physical activity of the patient should be taken into account. On physical examination, The weight is very important because insulin is known to increase weight. Comorbidities, hypoglycemia risk should be kept in mind, and investigations like fasting, PPG, and A1C I have already told. These are the patient-related factors, initiation with premix insulin or basal insulin. Very important slide for you to understand. Anybody who has a difference between fasting and postprandial of more than 54, that is 3 millimole, should be on premixes because the prandial sugar is postprandial increment is more than 54. If it is less than 18, you may start with basal insulin. So it is important to look at the baseline when you are starting insulin. Likely to manage on basal bolus therapy. अगर मरीज कहता है कि 4 बार इंसुलिन नहीं ले पाएंगे, then maybe premix should be used. If he or she says that this is okay with her, good control is important, then you should go for basal insulin. If there is large carbohydrate diet leading to postprandial hyperglycemia, yes, it should be premix insulin. And lifestyle which is unpredictable. The predictable lifestyle is majority of us do not have the right. While initiating insulin therapy, it can be a newly diagnosed type 2 diabetic, as I told, should be started on basal insulin depending upon what is the postprandial increment C, or it can be oral anti-hyperglycemic agent फेल्योर 2 से 3 दवाई से ज्यादा अगर चल रही, still A1C is not under control, it can be basal insulin, and if the postprandial increment is much, then more than 54, it can be premix. You can add GLP-1 RA at the beginning. Initiating with premix insulin, it covers both fasting and postprandial. It represents 6.8% of total global market, but in India, premix is preferred. Even for type 1 diabetes, what to say of type 2 diabetes? It should not be used, premix insulin should not be used in type 1 diabetes. It is only and only type 2 diabetes. Basal bolus therapy should be preferred. Premix insulin formulation may be conventional insulin, analogs. Typical Indian phenotype favors premix insulin, high intake of carbohydrate like we Indians take. It is high baseline PPG value in type 2 diabetes should be preferred premix insulin. Convenience and simplicity should not be looked for when you are using insulin. Initiating basal insulin therapy alone is most convenient once a day, including both intermediate acting and long acting analogs, maybe glargine, detamir, or degludec. Lower risk of hypoglycemia with these analogs. For individuals of type 2 diabetes, starting dose for basal insulin is 0.1 to zero point 0.2 units per kg per day, depending upon hyperglycemia. It reduces hepatic glucose output. Basal insulin Remember, basal insulin has a ceiling effect. Increasing dose may not be valid reason in the risk of over basalization, as our own ADA guidelines say. Basal insulin therapy is escalated to combination injectable therapy when the basal insulin dose is more than zero point 0.5 units per kg body weight per week. We may use combination with GLP-1 RA, must follow principles for if you are starting insulin therapy. Progressive nature of type 2 diabetes should be explained. Avoid using insulin as a threat or a sign of failure, maybe of doctor, maybe of patient. Many adults with type 2 diabetes eventually require benefit from insulin. Temporary use of insulin in various acute situations I have already enumerated. Educating and involving diabetics before starting insulin is very important. Self-titration should be promoted. Education regarding monitoring, nutrition, physical activity, prevention and treatment of hypoglycemia should be there. With that, thank you very much.